And dear colleagues, good afternoon. I would like to thank Professor Badreddin Mustafa for his kind invitation and also organizing committee. My topic is the tympanic membrane retractions and grafting. Tympanic membrane retraction is a condition characterized by a partial or in toto collapse of the eardrum, narrowing middle ear space, followed by severe atrophy, formation of adhesion, and related sequelae in advanced stages. And it is closely associated with the development of the cholesteatoma. When we talk about the retraction pocket, actually we have to talk about the pressure regulation in the middle ear. But I will skip some of the theoretical issues. And also formation of the retraction pocket is associated with the Eustachian tube, chronic dysfunction of the Eustachian tube. And it may be closely related to otitis media, and the chronic inflammation may underlie the retraction pocket. And recently, some recent new theories contribute to our knowledge, which is the mucosal traction theory by Professor Jackler. And as for the attic retraction push, Professor Marchioni and Presutti nicely investigated the endoscopic anatomy of the attic and all middle ear space, and they found the tensor fold formation of tensor fold, either complete contribute to epitympanic dysventilation. For sure, additus problem and supratuberous recess anatomy also contribute to formation of the attic retraction pockets. I have to skip some of the theoretical issues. As we all know, TOS grading pars flaccida retraction pockets and SADE grading grade that pars tensa retraction. Actually, I will start with the evaluation of the retraction push. It should include history taking, complete ENT examination, microscopic, and also autoendoscopic ear examination, pneumatic otoscopy, and tympanic membrane mobility check during the Valsalva maneuver, and some hearing test, tympanogram, and in some cases, CT and or MRI is required. For example, if there is a hidden retracted area, and if there is a history of infection or drainage or accumulated debris, or an operation further than ventilation tube is planned, so we need imaging. I will skip theoretical treatment issues. If any of you wanna talk about this, we can talk these issues in coffee break. I will start with my cases. This case, 9-year-old female, and she had tympanic membrane adhered to incudostapedial joint, and the whole tympanic membrane is very atrophic, and there was no fluid in the middle ear. This is stapedial tendon. How can I see the time base? Okay, thank you. This is atrophic tympanic membrane. So we just simply inserted the ventilation tube, and this is the 1 month after the operation. Ventilation tube stabilized the condition. So she also needed to regular follow-up if there was a improvement or progression. And second case was a 10-year-old female. Otoscopy showed attic retraction and otolysis media with effusion on right side and stage 2 pars tensor retraction and fluid on the left. We simply put a bilateral ventilation tube and the tubes stabilize the condition. This adult case, I will skip the similar case. And this lady, 12-year-old, she complained about right otology. And she had a normal hearing. And this is the CT. We see the tympanic membrane, posterior superior quadrant of the tympanic membrane at a deep push and adhered on the equinocerebral joint. And in the operation, we found a meningostapexy. Here, the adherence on the joint, but ossicular chain was intact. Tympanic membrane was elevated off the stapes, and posterior quadrant reinforcement with a cartilage sheet was performed. This is template. I used conical cartilage. We prepared the cartilage. Postoperatively, she had a little bit decreased hearing, but was still in normal limits. This case had a retraction and dry perforation and in posterior quadrant of the left tympanic membrane, and he had conductive hearing loss. In the operation, posterior wall of the ear canal was deleted to reach the medial most part of the retraction pocket, and tympanoplasty with a piece of fascia and ventilation tube insertion performed. I firstly placed the ventilation tube, and then I placed the piece of fascia and supported with gel foam. And this case, 19-year-old man, and he had a history of recurring ear infection. He had a left attic retraction, and he had normal hearing. We performed limited atticotomy. This is attic area and posterior superior quadrant of the tympanic membrane. Similarly, I approach. Again, I use conical cartilage and also fascia. I horizontally place a sheet of cartilage here.
Dear doctor, your time is up.
Do I have 1 or 2 minutes? I completely closed that area and I placed the fascia over the cartilage sheet. Postoperatively, hearing was, he didn't change the hearing. And I have several cases, actually. This patient at the first at the perforation posterior superior quadrant, but when the operation time, during the operation time, I noticed that the perforation was closed, but deeply retracted over the joint. Endoscopically, I entered the middle ear and I noticed the meningostapexic, left ear tendon. I elevated off the retracted eardrum, but unfortunately, my friend didn't record the rest of the operation. And there was a long erosion of long process of incus. I put the titanium perp and cartilage. And this was a 13-day appearance, cartilage and normal tympanic membrane. Cartilage, similar cases. Actually, this case could be interesting. Sorry. Can I cannot move the cursor. Again, attic and posterior superior quadrant retraction. This operation dated back to 13 years ago. When I had to repair the pars tensa, I mostly use pedicle cartilage. Again, ventilation tube insertion. Recently, I saw that patient, cartilage here and the previous ventilation tube site here. And sometimes cartilage prevents the further retraction. This is the cartilage graft and all previous ventilation tube site. Sometimes fail to protect the ear. You can see the gradual retraction of the cartilage. Thank you very much for your attention.
Thank you, Professor Sattar. Now we'll continue. Well, good afternoon once again. I first of all have to apologize if we will have some overlappings, but I mean, it's the same topic. So I'll talk about retraction pockets in children. We all know why retraction pockets is very important, as it can lead us to cholesteatoma. We all know what it is, retraction pocket, but we have to have in mind that it's not the same thing as atelectasis. As in atelectasis, you can have a tympanic membrane which is reduced to epithelial layer, and also it's not adhesive otitis, or we can call it even better, fibroadhesive otitis, as in this situation you have a middle ear which is full with fibrous scar tissue. So first of all, what are the main risks for retraction pockets in children? Recurrent acute otitis media, early onset of acute otitis media, chronic otitis media with effusion in older age, family history of chronic otitis media with effusion, all those nasal problems. And we always have to have in mind that in bilateral retraction pockets, diagnosis and treatment of rhinopharyngeal disorders is necessary. So we all know that we are not completely sure about pathophysiology of retraction pocket. It can be due to congenital weakness of fibrous layer of pars tympa of the eardrum. But mainly the author agreed that it's a result of eardrum weakness due to chronic inflammation, usually due to recurrent otitis or chronic otitis media with diffusion, and due to the changes of the middle ear pressure and Eustachian tube function. Only a small group of authors think it's due to developmental incoordination of the posterior superior region of the annulus and middle ear aeration pathway. Also, we know that there are so many classifications. First one was by Sade, then it was Onishi. As we already heard, Professor Tosh, he was famous for his pars flexida retraction classification. Then Professor Charachon, in my opinion, very, very valuable classification because it was first clinical classification. And also my mentor and my great Professor Trambay in 2005. And made the most important Erasmus classification for children because it was the first classification for the children. And it had 5 stages, and 5th stage was actually cholesteatoma. There was another interesting classification from UK authors, but it was so complicated that it didn't got to attention. And then it was an interesting article from Montreal authors, which say that all currently described staging system of retraction pockets are worthwhile for follow-up, research, and teaching, but their influence varies between different authors. That means that we can't have one classification and that we will manage the same retraction in the same way all around the world. So we think that the most important are criteria for staging evaluation, like fixation of retraction, localization, extension, controllable or uncontrollable, desquamation, self-cleaning ability, otorrhea granuloma perforation, hearing loss, acicular chain erosion, and what we think as a criterion is most important is progression of the retraction. So all other classifications are at the moment useless. This is a classification which is very similar to Charachon classification in 3 stages. And this is a classification according to progression. As we said, the progression is very important in retraction pockets. So we are very aware what to do in stage 1, in stage 3, and stage 4, because in stage 1 we will definitely perform, in many cases, watchful waiting. In stage 3 and 4, we will definitely operate. There you can see that there is a famous sign as formation of Herodion, or what French people say coulée de lave, because it looks very much like a volcano eruption. And of course, cholesteatoma, we will operate. But mainly we disagree in this stage 2, which is very important in children, as its posterior superior quadrant is usually very frequently involved in children, then a acicular adhesion without lysis, and also minimal symptom hearing loss, less than 20 decibel, which is also interesting in children because sometimes that can be normal hearing in children. So what we do in our clinic, we always perform diagnostics by automicroscopy, autoendoscopy. We precisely describe acicular condition, epitympanum and retrotympanum involvement, signs of activity, and possibility of follow-up. Also, we do pneumotoscopy, Valsalva maneuver. We also, whenever we can, perform audiometry, tympanometry, CT we'll discuss a little bit later, and follow-up to evaluate progression of the disease. So what about CT in our department? We think it's indispensable in signs of serious disease. And sometimes we think even if we didn't find the cholesteatoma, which we will operate, that it's easier to follow up if we have a CT scan. So what are those important signs of serious disease? Localization of retraction. Is the retraction controllable? So if it's not controllable, self-cleaning inability, recurrent infection, purulent discharge, ossicular and posterior superior canal wall destruction, hearing loss which is higher than 35 decibel, and progression during watchful waiting. So what about management? We have to be aware that early as advanced disease, symptoms may be minimal. Of course, in advanced disease, surgery is obligatory, and if you have hearing loss as well. What we do reinforcement tympanoplasty. We always in children perform Kolha cartilage graft. There is also a question if we have chronic otitis media with diffusion, we'll put ventilation tube, and we will post-operatively follow up, clinically of course, each 6 months until 2 years after the surgery, or once a year until 10 years after the surgery. Radiologically, we'll perform MRI after 2 years after the surgery or even earlier until 5 years after the surgery. What about ventilation tubes? We will always put ventilation tubes if we have controllable retraction with chronic otitis media infusion and hearing loss. If we have mobile but progressive retraction in children, and of course, which is very important in children, if the retraction is fixed on long process of the incus without lysis. Some authors do preoperatively retraction pocket elevation and tympanic cavity aeration. We do not do it each time. So what about tympanoplasty according to Eustachian tube dysfunction? Some author says that if you have a retraction pocket without Eustachian tube dysfunction, then you can perform tympanoplasty without cartilage graft. We will perform always in children cartilage graft. If we have Eustachian tube dysfunction, then we'll go for medial or lateral grafting. We started some lateral grafting, but we were not very satisfied. It was just the beginning, so we had some lateralization and blunting. So we keep on medial grafting, in which we have quite nice results. Of course, during surgery, if it's necessary, we'll put ventilation tubes. And what about if you have intermittent Eustachian tube dysfunction, then we'll take care about prevention of risk factors. Some authors discuss about ventilation, balloon dilatation of Eustachian tube. We do not have much experience in that, especially not in children. So what about our technique? As I'm a French student, then we started with this technique, double cartilage plate. So we always perform this shield tympanoplasty. And if we have missing superstructure of the stapes, then we'll perform this cartilage plate or double plateau. And we usually do it without a perichondrium. As you know, there are some Italian authors that do it with perichondrium to have a better junction with the tympanic membrane, but we do it without, as we think it's more rigid connection and less energy and sound transmission is lost. And as we all know, and according to the literature, that the results depends on preoperative hearing and postoperative chronic otitis media with diffusion. This is our research, which lasted for 10 years, and it was finished just before Corona time in 2020, because we wanted to have at least 2 years follow-up. And as you see, our results are quite okay, but they're not so good as French results. But we have to admit that we had the most patient in that third group, which is the most difficult group to operate. And we also have 2 patients in the first group, which most probably nowadays we won't operate at all. So from our point of view, from my department, we will send you a take-home message that if you have bilateral retraction pockets in children, you always look for risk factors. There is no urgency for surgery unless hearing loss is present in children and there is serious disease. Most important signs for disease progression in children are young age, bilateral disease, craniofacial malformation, poor skin tolerability, ossicular lysis, and sniffing, which is often seen in children. So we always have to have in mind that uncontrollable retraction pocket can hide huge cholesteatoma, so whenever you can think about CT scan. And I send you a great kiss and hello from my Mediterranean oasis. It's the island of Cres in Croatia. Thank you. And now I invite our next speaker, Professor Ben Gambra.
Hello. Hello. Thank you for inviting me to participate in the session tympanic membrane retraction and grafting, and I will talk about cartilage tympanoplasty and retraction pockets. Indications of for surgery in retraction pockets are now well known. These include mainly advanced pockets and pockets with signs of severity on otoscopy, advanced pockets with epidermal invagination or lava flow, pockets with otorrhea, fixed pockets with erosion ossicles and conductive hearing, resulting conductive hearing loss. The station of the contralateral ear is a K factor 2 in decision of surgery. And the CT scan, donc the CT scan can identify ossicular erosions and any suspicious opacities in the middle ear that indicates surgery. What about goals of tympanoplasty? First, to remove the retraction pockets, to remove the epidermal invagination, the epidermal tissue, and to complete dissect the retraction pocket. The dissection must be complete and done and carefully carefully from the middle ear structures. The reconstruction of the tympanic membrane and any defect bones are imperative to prevent recurrences, new retraction, ossicular lesions, and secondary cholesteatoma formation. The stability of the results, anatomic and functional results, are indicative of the success of surgery. I remove the cartilage systematically from the concave. It provides sufficient quantity, and it forms a firm support to prevent retraction. We remove the perichondrium from the convex side of the cartilage, and we modulate the cartilage with a scalp. The little lamellae can be used to perfect the reconstruction of the tympanic membrane. Here we use the cartilage graft in its all thickness to reconstruct first the anterior part of the tympanic membrane. We can see here the stapes, and here the malleus, the handle of the malleus. And we complete by placing the second part of the cartilage placed on the stapes of the head of the stapes. Here we cut an encoche in the cartilage, which is put on the stapes, and here we choose to place thin slices of cartilage in palisade technique. Finally, we put the perichondrium on the cartilage. In ossiculoplasty, cartilage, the stapes can be enhanced by cartilage put in double plate, by prosthesis, partial prosthesis, or by ossicular incus modulate, for example. In type 3 cartilage, the placement in type 3 ossiculoplasty, cartilage can be placed on the ossiculoplasty, and the cartilage can prevent the extrusion of the prosthesis, and then we can have a more anatomic stability and a better long-term hearing outcomes. For concerning cartilage support, donc we put cartilage graft mostly in lateral to the handle of the malleus. We should put the cartilage on the bone frame to have a stability of the assembly. Total or subtotal reconstruction of the tympanic membrane is recommended to prevent retractions, and we note a decreased rate of recurrence retraction with systematic use of total or subtotal cartilage reconstruction. Some results, post-operative results. on the scan, the cartilage have a nice curvature. The middle ear is pneumatic, well pneumatic, and over time the cartilage becomes homogeneous, and it can integrate the structure, the structure of the middle ear. We have a short video concerning the dissection of retraction, posterior retraction pocket. Donc we dissect the lesions, the pocket. It's a posterior uncontrollable pocket. We dissect donc the invagination, the epidermal invagination. We expose all the disease. We must remove carefully all of the disease posteriorly. Large defect bone and the ancus, the stapes, and retraction pocket is fixed on the head of the stapes. Extraction of the ancus. It's clean and posterior, and we will control the cavity. Clean, and we will modulate the ancus, which is put on the stapes, and finally we reinforce we reconstruct the defect bone and the tympanic membrane with cartilage. Cartilage on the frame bone.
Dear doctor, your time is up.
Thank you very much. Thank you, Professor Ben Gamram. Now I've asked Professor Abdallah to come and give us his lecture.
Mr. Chairman, thank you. First, I would like to thank Professor Badruddin Mustafa for his kind invitation, and thank all you for participation. Nowadays,
we will think about simultaneous bilateral meringoplasty as a single operation. Why not? The theoretical risk of iatrogenic sensory neural hearing loss during surgery has induced a reluctance to perform bilateral meringoplasty among auto surgeons for a long time before. And sensory neural hearing loss is not only due to surgical procedure, I mean traumatic or iatrogenic trauma. Sensory neural hearing loss may be due to infection, especially viral infection, viral antiviral vaccination, metabolic disorders, trauma, ototoxicity, not only due to surgical trauma. To evaluate simultaneous bilateral meringoplasty as a single-stage operation, to think about the cost, to think about the waiting list, to think about the hospital stay. So we think about bilateral simultaneous meringoplasty as a single stage operation, even if you get one free, buy one, get one. Respective study was carried out between January 2008 up to September 2011, included 30 patients with 60 years. All these 30 patients with dry central perforation, the Barstein's caused by Tympanic disease in the otolaryngology department of the Gazig University Hospital at the same period. They all subjected to full history taking, general and local examination, endoscopic and microscopic examination, audiological evaluation, and sometimes CT. The selected patient must have dry tympanic membrane perforation to the healthy middle ear mucosa for at least 2 months before surgery. Hearing level was corresponding to the size and site of the perforation, and no suspicion of a circular chain defect or other pathology, and good Eustachian tube function. We exclude the patient underwent any type of mastoidectomy on the same operative day or at the previous date, or who had any types of previous concurrent or non-concurrent vesicular reconstruction. Patients were firmly informed about the technique and their written consent after discussion of the risk of surgery and alternatives. The size of the perforation and the key factors was the key factor in determining the use of certain operative technique, and you have your own choice to take which technique and which graft would you like to do. In our study, general anesthesia was used in all patients. Approach was tailored according to the size of the perforation, whether post-auricular or end-oral or permeatal. The grafting material may be chondroperichondrium, as we have preferred in this study, but you can use any kind of grafting materials, temporalis fascia, cartilage, and whether you prefer. I want to express my deep thanks to this type of graft, chondroperchondral graft, with peripheral chondral and central precondial. This type of graft gives me fixation, good stability of the graft, and good hearing result. The peripheral chondral graft give me a good stability of the graft, and the central island of precondium only gives me the good hearing result with tympanic membrane mobility. Gel foam was inserted only on the lateral surface of the tympanic membrane, and 2 packs left in the external canal. Pressure dressing is left for 2 weeks. Patient received systemic antibiotic cephalosporin for at least 1 week. Eardrops were described after removal of the outer packs for at least 2 weeks more. Patient was surged in the same day. Surgeon instructing not to blow their nose vigorously as they can dislodge the graft. And avoid water entry into the ear. All the precaution must be taken in consideration. And our result was successful closure of the tympanic membrane was defined as intact tympanic membrane for at least 6 months post-operatively. Success in terms of hearing was defined as improvement of at least 10 decibel or greater on 2 consecutive frequencies compared with the preoperative data. Here's our results. The size of tympanic membrane perforation was small in 12 cases, medium in 34 perforation, and large in 14 perforation. Success in terms of hearing was defined as improvement of 10 decibel or greater, and patient satisfaction must be taken in consideration. Sometimes, if you have the success with hearing and still there is small, even residual perforation, it can affect the patient quality of life, especially if he is swimmer or would like to take a shower in seashore. That's why patient satisfaction must be considered in successful output. Is a pure tone audiometry preoperative and postoperative must be done for documentation, and the mean preoperative hearing threshold, we mean postoperative hearing threshold, and the mean hearing gain must be at least 10 decibel. So tympanic membrane not only performs the conduction of sound wave across the middle ear, but also serves as a protective function of the middle ear cleft and shields the round window from direct sound waves, which is referred as sound window buffer. In conclusion, therefore, it seems that observing and considering the primary principle of ear surgery, no more sensory neural hearing loss was appeared, and there is no need to be worried about or to be sensitive in this regard. Thank you.
Thank you, Professor Abdullah. I kindly invite Professor Jorgen Gillar to give us his lecture.
David. First of all, I would like to thank the organization committee, especially Mr. Bahadur Eldain, for inviting me this distinguished congress. Today, I'm going to talk about the underwater endoscopic ear surgery for retraction pockets. Yes. First of all, I have no financial disclosures or the conflicts of interest to presented materials. The retraction pockets, everybody knows, is a pathologic invasion of tympanic membrane through the middle ear cavity, and considering the potential progression to cholesteatoma, the current diagnosis and the surgical management is crucial in this case. And the endoscopic ear surgery, a good option for this kind of cases. Endoscopic ear surgery provides is a wide view, and even in hidden areas, you can see during the surgery, especially in the retraction pockets. So there have been a number of recent advances in this surgery technique. The one of them is the underwater technique. This picture from Sharm el-Sheikh. And this novel procedure first reported by Yamauchi for the plugging in the superior semicircular canal dehiscensis, and then Nishike and Chen reported for cholesteatoma cases with endoscopic use, and the Wang compared the results of continuous drilling underwater and the intermittent drilling with endoscopic patient. So I is inspired for these techniques, and I modified it for me. This is the equipment. I will explain it. First of all, the endoscope sheets. These sheets are usually used by the orthopedics for meniscus surgery and arthroscopy. This 505 millimeters width and suitable for 4 millimeter telescopes. And another dimension is the 3 millimeter and 4 millimeter sheet. This high flow system in the tip of the shield, limiting the disruptive turbulence during the underwater technique. And the E-type 2 irrigation sets for using by the urologist for prostate surgery to help us for continuous drilling and controlling the debit for saline. And the diode laser is a good device for endoscopic surgery. This device is approximately 980 nanometer wavelengths and high absorption with the pigmented tissues, and the low absorption in the water is important for the underwater usage, and to need to touch to transfer to energy. So, sorry. And the regular bore system is enough for in these cases. And the special designed aspirator dissectors is very helpful for the removing the clots or other bone dust from the surgical field. And the endovision system, very important. The high definition 4K systems is very helpful for in this retraction pocket surgery. And this is the surgical setup. As you shown in here, the sheet and the endoscopes. The sheets connect to the saline perfusion with the E-type 2 irrigation system, and the saline solution overflowed out through the concha and the outside, and the pocket and suction is help us for removing the excess saline from the field. This is the I will share couple of videos. Yes, this is an underwater technique. You can see the air bubbles around the extra-auditory canal, and we use it as round dissectors, and we dissect the tympanomeatal flap. During this surgery, some annoying bleedings around the flap or the incision line can be controlled by the coagulation mode diode laser, and the assistant resident controlled the irrigation during this surgery. As you can see, this laser touch and control the bleeding. Can I? Yes. And then entrance to the middle ear cavity. As you can see, air bubble and the antrum, and you can easily dissect from the adhesion line very gently during the surgery, and the manually dissect with laser and the dissectors and the grafting. Yes. Another patient. Oh, can I? The surgery began with vaporizing the air cells, and then underwater will begin. This is the underwater period of the surgery. The section of the annulus from the posterior border of the external canal, and this is the chorda tympani, entrance to the middle ear cavity. So we control all the bleedings around the flap, and then yes, we elevate gently the retraction pocket. Everybody knows it's very important for residual or implantation cholesteatoma. And then during the surgery, we can see some air bubbles. And now we try to coagulate the mucosal capillaries with a laser, and then we can use such a blade, and then we will dissect the adhesion around the incudostapedial joint area. So yes, this is the dissection. We use some remnants of epithelia with laser. And finally, we remove the whole retraction pocket from the ossicles, and then with the grafting. I will skip some of them because of the time limitation. Another case, I will skip it. And this is the last one. This is a retraction pocket again. Start with, you can see a very good vision with underwater, because the water have a 1.33 magnification during this surgery. And then surgery proceed to elevation of flap. And then you can see sometimes with cholesteatomas, with these cases have middle ear cholesteatoma, white mass behind the intact tympanic membrane. You can aspirate underwater, even in underwater with aspirator dissectors. You can see another cholesteatoma part. You can remove it and look at. Please look at that. All the sac is intact, and the grafting. So our preliminary results of number of patients is 18. The graft success is 100%. And
Doctor, your
this
time
is the
is
last slide. Yes, advantages of underwater surgery, the magnification prevents the heat trauma during this endoscopic surgery, facilitates the removing the bone dust during the drilling and the providing a clear operation field, and the better dissection of retraction pocket epithelia, and better distinguishing between the mucosa and the epithelia and the cholesteatoma as well. And no need to wiping the lens during the endoscopic surgery, and it can be assist laser, diode laser, and the aspirator dissectors. The cons is difficult OR setup, need to extra equipments and need more than one assistance for pumping the irrigation, and the sheet increase the width of the endoscope, but it's not so difficult, I think. And the caloric effects, another important point. Irrigation, of course, done with in the body temperature, and the learning curve is another important point. Thank you for your attention. This is my last slide. Sorry, this is my last slide from Cairo. Thank you.